Shoulder pain is one of the most common musculoskeletal complaints we see in both primary care and specialty clinics. But not all shoulder pain is created equal, and knowing whether it's inflammatory or structural is critical to making the right diagnosis and choosing the right path forward. This video is for education and inspiration only. It's not medical advice. Be sure to consult a healthcare professional and double-check information with trusted sources. I'm Dr. Rezaian, a specialist in arthritis and rheumatology, and today we'll break down a comprehensive approach to evaluating shoulder pain so that you can differentiate what's systemic from what's mechanical. Shoulder pain can typically be classified into two broad categories, inflammatory and structural. The difference between these two isn't just academic. It changes how you approach diagnosis, workup, and treatment. Inflammatory pain often presents with deep aching pain that is worse at night and most noticeable in the morning with prolonged stiffness. It tends to improve with activity and gets worse the longer you rest. This is the classic presentation for conditions like rheumatoid arthritis, polymyalgia rheumatica, lupus, and other systemic autoimmune diseases. To evaluate inflammatory shoulder pain, consider a rheumatologic workup. ESR and CRP for inflammation, rheumatoid factor and anti-CCP, ANA for autoimmune screening, especially in younger women, CKLA-B27 and others based on specific concerns. X-rays may be normal early on, but chronic inflammation may show joint space narrowing, erosions, and osteopenia around the joint. In contrast, structural pain is usually mechanical in nature. It gets worse with activity, improves with rest, and is often associated with specific movements, overuse, or prior trauma. It's typically unilateral, and you can often pinpoint the location or motion that aggravates the pain. Some clinical clues help you differentiate. Inability to sleep on the shoulder at night may point to rotator cuff tendinopathy or inflammatory bursitis. Having good passive range of motion suggests no joint capsule involvement. Older patients, especially over 60, have higher likelihood of rotator cuff tears even without trauma. Also remember, shoulder pain can be referred from the neck, like C5-C6 radiculopathy. Now let's review key physical exam tests for structural problems. Neer impingement sign, pain suggests subacromial impingement. Hawkins-Kennedy test, pain implies impingement or bursitis. Empty can test, weakness or pain suggests supraspinatus tendinopathy or tear. Drop arm test, sudden drop indicates rotator cuff tear. Speeds and Jurgensen's tests, pain suggests biceps tendinitis. Apprehension and relocation tests, pain or apprehension suggests anterior instability or labral pathology. Cross-body adduction test, pain at the AC joint suggests osteoarthritis. Once you suspect structural pain, imaging helps define the issue. Start with X-rays, AP, scapular Y, and axillary views. Look for osteoarthritis, bone spurs, calcifications, or a hooked acromion. If X-rays are inconclusive or soft tissue is suspected, use ultrasound or MRI. MRI helps assess the rotator cuff, biceps, labrum, and bursae. Let's bring it all together. First decide, is it inflammatory or structural? Ask about sleep, stiffness, and activity pain. Test passive and active range of motion. Consider the patient's age. Don't forget the neck. Start with X-rays, escalate to MRI or ultrasound as needed. Refer to rheumatology or orthopedics based on the likely source. Shoulder pain is complex, but with a structured approach, you can diagnose it confidently and efficiently. If you found this helpful, please like, share, and subscribe. I'm Dr. Rezaian, and I'll see you in the next one.